My name is Alyssa Brown. I am a professor of psychology at St. John's University and co-developer of AFCBT. I'm making this video to give you a primer on cognitive behavioral therapy, knowing full well that you have had experiences in the classroom and probably with supervision in this model, but thinking that it's important for all of us to get on the same page about the philosophy, theory, and some practical steps in cognitive behavioral therapy. In this next video, I'm going to be covering a few topics. I'll be discussing CBT and its definition, the role of the therapeutic relationship in CBT, theories of behaviorism, case conceptualization in the context of CBT, and assessment. Our first question for today is, what is cognitive behavioral therapy? There are a number of themes and characteristics that describe CBT that I'm going to review, again, to create a common lexicon, but also because I think we need to debunk some myths about CBT. As most of you know, CBT has a scientific base. All of the treatments we use have been tested empirically, both in terms of their efficacy, their work in these randomized trials, and their effectiveness. Are they working out in the real world? But what I mean here in terms of scientific is that we're going to use a scientific approach as clinicians. We're going to develop hypotheses about the world and test those. We are also going to use assessment over time to guide our practice. CBT is an active therapy. The clinician partners with the client to figure out goals, to try interventions, to role play those interventions in session, and to evaluate what changes have to be made in the therapeutic plan. CBT is focused on the here and now. That is not to say history isn't important. Clearly, in AFCBT, history is tremendously important. We think about the trauma history of the individual child, the trauma history of the caregiver, and to be culturally sensitive, we consider historical trauma. But what we are really trying to address is the present problems children and caregivers are having with affect, with parenting, with family conflict. Self-control and self-evaluation are central to CBT. Our goal, in a sense, is for the clients not to need CBT anymore. We're trying to give them skills and not just be able to use them with us in session. We want to teach them those skills so that they can do them on their own. We ask them constantly for feedback, formal and informal, to evaluate whether the model is working. CBT has a learning focus, and this is one of the things I love about it. As I train clinicians across the country or train my doctoral students, I am always giving rationale for what I do. I am giving a background, both theoretical and empirical. CBT is exactly the same way. We give our clients a real understanding of the why, and then we teach them the what, and then we teach them the how. And all three pieces are done in a psychoeducational framework. CBT is collaborative. As I mentioned earlier, client-therapist, that's a partnership. The family brings lots of information about what they know, what they've tried before, how they understand one another, and we as clinicians bring knowledge about skills, about psychoeducation. It really is a team effort. CBT, in spite of a common myth, is individualized. Yes, we work from a manual. We certainly do that in AFCBT. But it's hard for me to pinpoint a typical AFCBT case. Every family is different, the needs are different, and using assessment to guide practice allows us to individualize the work. CBT in general and AFCBT in particular take a stepwise progression. We start with education, then we move to emotions. Can we label them and understand them? We need that in place before we give regulation skills. Affect regulation skills are not helpful if our clients can't identify their triggers. For caregivers, we give them the affect regulation skills before we teach them better parenting. They need to be able to calm themselves down to make good choices about parenting. So in both cases of child and caregiver, that stepwise progression, building blocks, is central to AFCBT. CBT is a short-term approach. It accomplishes improvements in symptoms and family functioning in a relatively short period of time. And the nice thing about CBT is that because these various interventions, such as relaxation, cognitive restructuring, parent training, have all been evaluated separately, they then can come together in a treatment package based on the needs of families. What is the role of the therapeutic relationship in cognitive behavioral therapy? In spite of what some might think, it is central. I would argue that it is necessary, but not sufficient. So it is central to accomplishing many of the techniques in CBT, such as a trauma narrative. But that therapeutic relationship isn't enough. We need the skills on top of the IAMS. There are a number of functions of therapeutic empathy, which is an integral part of developing that therapeutic relationship in CBT, beautifully laid out here by the authors. 1, it helps us establish the therapeutic relationship. 2, it helps us with assessment and data gathering. If you are trusted, you will learn more. It helps us facilitate the case conceptualization to put ourselves in our client's shoes as best as we can. As I mentioned earlier, it enables the CBT techniques to be tried and practiced. Clearly, the therapeutic empathy is important for the maintenance of a therapeutic relationship. And as we all know, therapeutic empathy in and of itself is a therapeutic agent. It breeds change. Now, it's interesting, there has been some research on the therapeutic relationship in CBT, and I'm not surprised to report that it is one of the strongest predictors of both treatment process, meaning people showing up, people staying in treatment, and outcomes in children, adolescents, adults, across disorders, across different kinds of therapy. As I said, it is necessary. It's just not sufficient. Early in treatment, youth who receive manual guided treatment have significantly higher observer-rated alliance than those who received usual care. And I mention that again because of that myth that if you have a manual, it's less successful, less individualized, and it does harm to the therapeutic relationship. Here, in fact, we have some data that suggests the opposite. Now let's go down to just basic theories of behaviorism. And this will remind most of you of that first Psych 101 course that you took in college. Starting with Pavlov's conditioning paradigm, which I think is really helpful in thinking about the origin of certain behaviors, such as anxiety or aggression. We have an unconditioned stimulus, such as a loud noise, that is associated with fear. This is biologically predetermined in most of us. And what happens with the conditioning is that that loud noise starts to be associated with a toy because it always happens at the same time, and therefore that toy is then associated with fear. Again, this is a very good explanation for the origin of anxiety and also trauma triggers for the traumatized kids we all work with. Building off of that basic Pavlovian paradigm, Volpe explained how triggers really can develop over time. Through stimulus generalization, our clients start to apply that learned response, the conditioned response, to many stimuli associated with the conditioned stimulus. So if you were sexually assaulted and there is a certain cologne that the perpetrator was wearing, it might be difficult to walk onto the first floor of a department store because you have generalized that perception of danger to associate it with the smell. Now, clients also are able to make discriminations between conditioned stimuli, and it allows us to create a new response by making the stimuli significantly different from the original one. So when we teach relaxation, while we're exposing our clients to those cues, to those trauma triggers, they learn to separate. And they learn that although the original situation was in fact dangerous, all of these things that remind them of the event, like a smell in and of itself, is not dangerous. And by shaping, we move from the newly conditioned stimulus associated with calm to the original conditioned stimulus, which was associated with fear, and we do that in increments. And that is something that Volpe talked about in the development of hierarchies and relaxation. Again, as a reminder, this model really explains the initiation of fear and triggers through traumatic events. Now let's switch gears. Skinnerian conditioning is what I would argue maintains the misbehavior, maintains the avoidance related to anxiety. So in the simplest terms, there's a stimulus, and a child or a caregiver responds in a certain way to that stimulus, and then how that is reinforced in the environment will either increase the response or decrease it. In more common terms, we have an antecedent, a certain setting, things that are going on, people who are around, sights, sounds, smells, etc. Then there is a behavioral response to that sight or smell. For example, the woman I talked about earlier, the sexual assault survivor, smells that smell, her anxiety exacerbates, she leaves the first floor of the department store. So that is avoidant of that smell. As a result of leaving, the consequence is her anxiety comes down and she feels better in the short term, but over time she has maintained that fear. In fact, she may have even generalized the fear to other things that she found on the first floor of that department store. The antecedent behavior consequence paradigm also explains the coercive parenting that we see in AF-CBT families, where a child is in an environment, wants something, enacts tantrumy kind of behavior, the caregiver ignores, child's behavior gets worse, the consequence is to respond in a negative way, but that's still attention. Even though the caregiver is yelling, even though the caregiver is hitting, the child still gets the attention that he or she wanted, and therefore that behavior is reinforced. So that Skinnerian or operant conditioning is explaining the maintenance of fear through avoidance, can explain those triggers, and it also can explain that coercive cycle of aggression and the role of parenting in reinforcing it. I want to switch gears one more time and talk a little about case conceptualization in CBT. This is really, it beautifully falls out of these two models I just talked about, Pavlovian and Skinnerian conditioning. Our case conceptualization framework in CBT is called a functional analysis. often referred to sometimes as functional behavioral assessment. And the idea behind functional analysis is we want to know why. Why is that particular behavior being maintained? We want to understand the function of that behavior. To do that, we need to understand the antecedent, behavior, and consequence in that situation. The first step, I think, is best, is to look at the behavior itself. What do we know about this tantruming behavior? What do we know about this avoidance? First, think about those parameters around that behavior. How often does it occur? What is the frequency of that behavior? Secondly, what's the duration? How long does it last? Third, what is the intensity of the behavior? And here, I would say, really think about anxiety or that tantruming behavior. How severe is it getting? And last, think about the pervasiveness. In what settings is this behavior occurring, and in what settings is it not occurring? Now step back and think about the antecedents to the behavior. Who is there when it happens? What activities or events precede the behavior? Does the child engage in any other behavior prior to this one? Are there neurobiological factors that may be setting that child up to behave in a certain way? Those are important antecedents as well. What is the person thinking or feeling in that moment? Again, thinking about that triggering. What are the smells, sights, sounds, touches, or tastes that may be affecting that child or caregiver, that trauma survivor? And lastly, what are the consequences of the behavior? What happens after the behavior occurs? How does the person enacting the behavior react? Do they seem calmer after they've had this tantrum, which may be reinforcing the tantrum? How do people in the environment respond? Are parents running to that child and trying to calm him or her down in a way that's very reinforcing of attention? What does the individual get out of following that behavior? So here are some common functions that we see when we conduct our functional analysis. One is attention. We see this a lot with kids, as I mentioned, where that is their end goal. That is their why. That's the purpose of their behavior. So for example, a teenager who says, I'm so fat, I'm so ugly, is really hoping that her peers will say, no, you're not, you're pretty, you look great in that. That's what she's looking for. A second common function is escape. Think about a boy who really is struggling with math. And he knows that math happens every day at 11 o'clock. And oddly enough, at 10:55 every day, he starts to act up. And the teacher, who's so frustrated by this point, sends him to the assistant principal's office. And as a result, he escapes from having to do the math. Another common function is a reward. Most of us go to work so that we will get paid. Another example is a child who seems to know to tantrum when he and his parent are in the cereal aisle at the supermarket. And as a result of the parent wanting to settle that tantrum down, the child gets the sugar cereal that the parent really did not want to buy. And a final function I want to mention is sensory stimulation. We see children who are on the spectrum engaging in perseverative behaviors to have that sensation happen in their bodies. Now, as you think about the theory and how it falls into our functional analysis, we really need clear methods of assessment so that we can be successful in figuring out the why, and really understanding the behavior, its antecedents, and its consequences. There are a number of methods to use with behavioral assessment, and all have pros and cons. Unstructured interviews are very easy to use. Most of us do a clinical interview when we first meet with a family. The problem is they're not standardized, they're not really reliable. If I administered one with one family and a week later Dr. Kolko did the same, we may not come up with the same information. And they're not valid. We don't always know that they are assessing exactly what we hope they will be assessing. On the flip side, you have a semi-structured diagnostic interview, very thorough, very structured, good reliability, good validity, but it takes a long time, and you have to be trained to a certain level in administering it. Direct observation is a wonderful way to collect information about a family, about a dyad, or even about an individual. That, too, needs to be coded in a certain way. That takes effort and clarity, but it gives you outstanding information. Questionnaires are a little bit easier to administer. What we worry about there is social desirability. People often write down how they want to be perceived. Psychophysiological measurement is an excellent form of assessment, really gets us to understand what's happening in the body, but not everybody can afford the equipment. And lastly, archival records. This is real-world data. Going to Child Protective Services, going to juvenile justice and the courts, and finding out how often something happens, when it tends to happen, et cetera, et cetera. Now, the reliability of this data also tends not to be as strong. So the things to consider when picking any behavioral assessment tool are reliability. Is it consistent, regardless of who administers it, who fills it out? We have some consistency. Is it valid? If we think it's a measure of PTSD, is that what it actually is measuring? And is there utility? Is it helpful to you in that moment? And one thing I would add to this list is we have enough measures today that have really strong reliability and validity and are available in multiple language and are in the public domain. And so that really minimizes the cost to all of us. So the last thing I want to talk about is how this all fits together. We have our assessment tools, we have the constructs that we want to be thinking about specifically in AF-CBT. How does this come together for a functional analysis? Well, our antecedents here are many, but they include a history of conflict. So really assessing the trauma history, both community, culture, and also what has gone on specifically for this family. We want to know about current stressors that might be setting off the kid or the parent to enact a problematic behavior. Next, we want to think about that problematic behavior, both in terms of the children and the caregivers. So some things to assess are conduct problems, aggression, anxiety, avoidance, post-traumatic stress, depression, family conflict, parenting, etc. Now, reinforcers, this really is where the parenting becomes quite important. So how is the parent responding to these different behaviors, both in themselves and in the child? So when we talk about parenting, we need to think about parenting skills, but also what about the parent's level of anxiety, PTSD, and stress? Other reinforcers that we need to consider are risky behaviors that help a teen manage anger and anxiety, such as substance use. And in AF-CBT model, we are able to build this functional analysis and then start to link it to the available treatment components. And that is going to be a really critical part of what we talk about when we start discussing cases. So here I have included some web-based resources for assessment. They all have different strengths in them, and they allow for that ongoing monitoring that is so important from that scientific perspective. Hi, I'm Alyssa Brown, and I'm here to talk to you today about our second primer in cognitive behavioral therapy. Today we're going to talk about the framework and some CBT components that will be used throughout every session in AF-CBT. I'm going to begin by talking about social learning theory, and then I'm going to talk about psychoeducation. I'll present some science and some how-tos. From the psychoeducational framework, I'll then start to discuss three different types of interventions: physiological, cognitive, and behavioral. And then lastly, I'll talk about how we generalize everything that happens in session out into the real world through home-based practice. As I mentioned in the last primer, CBT is really psychoeducationally based, and there is strong theory that explains why each of the CBT techniques is useful. Here, I want to build on what I talked about last time when I talked about Skinnerian and Pavlovian theory, and now I'm going to talk about Bandura's addition, social learning or social cognitive theory. And what Bandura argued simply is that we needed to incorporate the environment in that Skinnerian view of stimulus-response reinforcer. Specifically, Bandura argued that the novel responses acquired through the process of successive approximation, so that's the Skinnerian idea of scaffolding. We learn one thing through how it's reinforced, and then once that behavior is acquired, continued reinforcement helps to shape behavior through successive approximation. And Bandura argued that one does not have to experience all of that directly oneself, that in fact we can learn through imitation. And social learning theory is concerned with how people's cognitions affect their social experiences, their behavior change, and their development. In other words, how I view the world through my observations, through watching and imitating others, will affect how I interact with people, how I change my own behavior because I've observed important contingencies with others, and my own development as a result will be impacted by that. So what we all observe through social learning theory is these response outcome expectancies. If I see somebody who is like me in some way, and I'm watching that person interact with someone else, and I watch how that person's outcome comes from how the first person responds to them, I am going to learn something about how I might interact with that same person. If I have a clear sense of those response outcome variables, and I feel like I know what will happen if I engage in the same behavior, that in turn affects my self-efficacy, my perception that I will have the impact on the world that I want. What falls out for me from social learning cognitive theory is this idea that we can use CBT to teach CBT, that we can learn through observation and teaching. So here are some of the techniques that we use all the time, that I use to teach CBT to my trainees, to senior clinicians when I'm teaching AF, or when I'm working directly with a family. One is modeling. So this is a process in which an observer, could be a client or a student, observes a person, known as the model, demonstrating a behavior from which the client can benefit. Observing a model provides really important information about what the model does and the consequence of those behaviors. There are a number of purposes of modeling. We use it for teaching, we use it to prompt others to change behavior, we use it to motivate people, we use it to reduce anxiety, and sometimes we use it to discourage maladaptive behavior. One example is using it as a clinician to coach caregivers with the goal that the caregiver then can coach the child to overcome avoidance. Modeling is a very, very powerful tool you probably use all the time and don't even realize it. A second strategy that falls out of Bandura's theory is something called behavioral rehearsal, which really just means practice. Behavioral rehearsal is a process in which clients or students practice the target behavior. The components of behavioral rehearsal are prompting, kind of get somebody going, shaping, scaffolding their behavior, feedback, and reinforcement, labeled praise, is our best bet here. And we use behavioral rehearsal for teaching affect regulation, social skills, parent training, etc., etc. Now let's talk about psychoeducation in particular. It has a few goals and a lot of opportunities. The goal of psychoed is to provide corrective information. We know that a lot of our families are misinformed about the effectiveness of corporal punishment, about where their kids' aggression and conduct problems come from, how anxiety develops, etc., etc. So our goal here is to educate with the second tier goal of normalizing, really helping people understand that it's not about blame, it's about understanding to motivate the change. Some of the topics that are covered in AFCBT related to psychoed would be exposure to family violence. How often does it happen? To whom does it happen? What are some common emotional and behavioral responses to violence exposure? Explaining what triggers are and how understandable they are. Now, we still have to explain that when the trauma was happening, that child may have been in danger. And when the child is triggered, he is not in danger. But it's still important to say how understandable it is that the triggering is happening and identify all of the times and places where it is happening. Also, when talking about the common emotional and behavioral responses, we can start to link our assessment results with this discussion. So we're not talking in the abstract, but we're specifically talking about the symptom picture that we see with this child and the functioning of the family. Again, educating to normalize. It's great to explain what some effective interventions are in response to the summary of the assessment material. Here is where we can really empower our families and make them feel like they're at the right place. We understand exposure to family violence. We understand the common behavioral and emotional responses. We know that your response is understandable given what you've been through, and we have a model that will fit your clinical needs. And a last topic that can be covered in psychoed is risk factors for relapse, which we do at the end of AFCBT. Now, whether you know it or not, you have lots of information at your fingertips for psychoeducation. One is the empirical information. There is wonderful science out there on all of these topics, on exposure to violence, common emotional and behavioral responses, effective interventions, and risk for relapse. But there's more. Your experiences clinically are wonderful ways of bringing information into the room. There, it's not about sort of explaining what happens to everyone, because of course you have only those families to draw from. However, it really makes families feel, again, like what they're going through is understandable when you say, I run a program for traumatized kids. We have that program because it happens so often. And that child who thinks she's the only one in the world who's been through this suddenly does not feel so alone. The last form of information that I want to mention is written literature by victim survivors. This again can really reduce that sense of being alone in what you've been through. There isn't a ton of research looking solely at psychoeducation. It tends to be part of a larger package, but there was a study done by McMahon and colleagues in 1981, and a more recent study actually done looking at a similar question, which is if you provide parent training without going into all of the psychoeducation about why you're doing each skill versus provide the parent training with that psychoed, you find significant differences. People who get the psychoeducation plus the parent training do better than the people who only got the parent training. At post-treatment, those who received social learning had higher knowledge of parenting principles, and at follow-up, we see higher knowledge, better child compliance, and a trend toward better parenting skills. Now, how do we do psychoed? We always begin with a rationale, and that is psychoeducation. Why are we teaching you any of these skills? Why are we asking you to write this narrative? Why do we want you to apologize to your child for the physical abuse? That all, providing that rationale, is psychoeducation. Now, there are lots of different ways to give a rationale. There's a theoretical rationale, as I've done with you already. We talked about different forms of conditioning, and we talked about observational learning. There's a research rationale. There's a ton of science we can draw from, and then there's a practical rationale. And this is about what they've tried, and what's worked, and what hasn't. So when they say, I use corporal punishment, but my kid's still acting out, you say, maybe it's not working as well as you thought it would. Maybe it's stopping the behavior in the moment, but it doesn't actually change the behavior over time. How about trying something else? And I think part of this rationale has to be empowering caregivers, that they are absolutely the most important person in their child's life, and therefore for us, they are the conduit. We are not going to make adequate changes with that child without the caregiver's central role. And with patients directly, whether it be children or caregivers, we have to talk about why they would trust us and providing psychoed about who we are, what we know, and what we don't. And that kind of, I think, takes some power out of our relationship and begins that collaboration. So let's start with the psychoeducational framework of cognitive behavioral therapy. This is what's called the tripartite model, or as kids call it, the cognitive triangle. And the idea here is that any emotion that we may have has a physiological piece, a cognitive piece, and a behavioral piece. So for the sake of linking this to AF-CBT, I chose anger. So if somebody feels angry, they're going to have physiological reactivity. Your heart may palpitate. You may have tight fists, muscle tension, sweating, a choking sensation. Any of those things can happen. But that's our physiological reaction. We also have a cognitive reaction. He shouldn't have done that. He did it on purpose. I'm going to get back at him. Those thoughts that are automatic that come into our minds exacerbate the anger. And then lastly, a behavioral response. It may be pacing, it may be yelling, and then at its extreme, it may include hitting. Now note the double arrows throughout our model. These things, each component of the triangle makes the other worse. So if I start having this physiological reactivity and I think he did it on purpose, well, guess what? My heart rate's going to go up, my muscle tension's going to get more, and then the other kid comes toward me and I swing. So this is really our understanding of the physiological, cognitive, and behavioral summary of our emotional responses. And the truth is, being angry is fine. It's just when it goes to an extreme and it's associated with these more extreme responses, the kids get into trouble with it, or caregivers get into trouble with it. So this model is used to explain the symptom picture that our clients bring us, because we can talk about their PTSD, their anxiety, their anger, their depression, and how it's maintaining through this response system. But there's another benefit to this psychoeducational framework. It sets up an explanation for cognitive behavioral therapy, and in particular, AF-CBT. Each of the components of the triangle is an opportunity for intervention. From a physiological point of view, we're going to talk about some skills that will help calm that body down. From a cognitive point of view, we have to identify and challenge those thoughts. And from a behavioral point of view, we need to figure out another way to handle those problem situations, and in the case of anxiety, how to handle that avoidance. So I'm going to go through each of the three now and explain the goal and some potential skills that are a part of the AF-CBT manual that you'll be learning about during your face-to-face training. So let's start with physiological interventions. What's the goal here? The goal is to ameliorate that physiological reactivity that tends to get our families into trouble. And the second goal is to promote a sense of mastery. If one feels like one can handle that reactivity, that makes a tremendous difference in the long-term prediction of a drop in post-traumatic stress and other symptoms. What are some strategies for physiological reactivity? Well, one is diaphragmatic breathing, also called controlled breathing or belly breathing. A second is muscle relaxation, where all of the muscle groups are tightened and then released to help our clients understand where the tension in their bodies lies. That's how we individualize the approach. And then they learn to release that tension. Our third possibility is mindfulness, which is really a way of getting very centered and includes actually a relaxed body and deep controlled breathing. I also mentioned exercise here because there are preliminary data showing its efficacy in the reduction of depression. And there are many other skills that probably help calm the body down. And I would draw from what the clients are already using: journaling, dancing, singing, whatever it might be. Now let's talk about cognitive interventions. The goals here are, one, to challenge that maladaptive thinking that, again, is getting our clients into trouble. The second goal should sound familiar. We're trying to promote that sense of mastery over our thinking, so instead of being overwhelmed by it, we know how to challenge it and move on from it. Some of the skills here include cognitive restructuring, problem solving, thought stopping, worry time, which is setting aside time for worry, and visualization, which is creating an alternative thought that includes sights and sounds, smells, etc., that can calm the body down. Now, just to talk a little bit about cognitive interventions, Beck is really, in many ways, the father of cognitive therapy. And what he argues is that the client's beliefs are tentative hypotheses. So this is hard for many of us, right? Because we are so dedicated to validating our clients' feelings, which I think is great. But this is sort of saying, be careful about validating the thought, because the thought may not be accurate. Instead, identify that thought and start to think about what evidence you have that it's true or not. Act like a detective or a scientist and look at that hypothesis. So we want to test the validity of the hypotheses by gathering evidence that either refutes or supports it. So here, very briefly, are some steps to cognitive restructuring. One is identifying automatic thoughts. Those thoughts that are like a bad habit, they pop into our heads, they are negative, and they are inaccurate. And when we are triggered, they come flying through. Second, analyzing the patterns of negative thinking that we see in those thoughts. They tend to be emotional reasoning. Because I feel anxious, I assume something bad will happen. Is it mind reading, where I'm giving a talk in front of a room and there's a woman in the back who's asleep, and I assume that it means I'm boring? And this happened to me years ago, and she came running up to me at the end of the talk, apologized, and told me that she had a 1-month-old at home. So looking at those patterns of distortions that is critical to figuring out what your next step will be, which is Socratic questioning, starting to gather evidence for and against your thoughts. And then based on that evidence, you develop an alternative thought. Cognitive restructuring is a very powerful tool. It's been shown to work by itself in hundreds of randomized trials. It can also be linked with other behavioral interventions for success. And for people with developmental delays or young children, we just simplify the procedure, but we still have luck with it. Now, behavioral interventions. What are our goals here? One is we want to minimize avoidance, and secondly, we want to build competencies, maximize healthy pro-social behavior. And some of the skills here that you see in AF-CBT are imaginal exposure, going through having an affective and cognitive processing of the traumatic events, parent training, social skills training, and communication training, which is so central to the needs of these families. And certainly, you want a safe mode of communicating before you start to talk about family violence. Now, we have the psychoeducational framework, and we have all these interventions that follow from it. In addition to maintaining that psychoeducational framework throughout therapy, homework is another one that will occur throughout therapy. What homework is a monitoring and practice of the skills that's conducted outside of session. The goal is generalizability. From a Pavlovian perspective, we call it stimulus generalization, right? We want to apply the learned response to stimuli that were associated with the conditioned stimulus, that healthy response. From a Skinnerian point of view, we say, well, we want to increase the consistency of the contingencies to the behavior. If the parent is doing great parent training in the role plays in your office, we want that to continue at home. So what homework really does is it facilitates change in our clients by providing them the opportunity to practice their skills, generalize them to their daily lives, and assume an active role in the change process. And part of that is figuring out what doesn't work. What happens when you, as the therapist, are not there, and bring that material back to session. And of course, if assessment is part of homework, that gives the therapist the opportunity to monitor progress and assess motivation. The data on homework are pretty strong, and the majority of studies show that homework compliance is associated with staying in therapy and doing better in therapy. And the outcomes that have been looked at in particular are depression, anxiety, and substance abuse. Interestingly, better outcomes are associated with specific therapist behaviors in assigning homework. And one of those things that is critical, and I've seen this in my own work, is discussing the barriers to completing homework. So when you give that homework assignment at the end of every AF-CBT session, and everyone has agreed to it, I always ask, what will get in the way? And that really makes a difference. Now, how to assign homework? Again, we're going to go back to the rationale. You can go with your theoretical rationale of stimulus generalization. You can have a research rationale about the likelihood of a positive outcome in treatment, or a practical rationale. And I have a few practical rationales here. If you say to almost any child, what are you good at? And they tell you, and you say, how did you get so good? They will say practice. And that's a great way to develop that buy-in, to have a conversation where you're asking the questions and the insights are coming from the client. A second rationale is just simple generalizability. They're with you for 45 minutes a week or 90 minutes when you see both caregiver and child, and so many other hours are spent without you. And the last is the cost benefit of treatment. We all know that the more you invest in something, the faster and more productive it'll work. There are always options to be given with everything in AF-CBT. We are both a trauma-informed and an aggression-informed intervention. Being a trauma-informed intervention recognizes that power and control have been taken away from our clients. We want to give them choices, and homework is a great example of that. Always discuss the monitoring of it. How do you know that it was done? How are you as therapists going to know how it went? Identify those obstacles and brainstorm solutions to overcome them. Here are some web-based resources that can be extremely helpful for all of what I talked about today, and really cognitive behavioral therapy more broadly. The Association for Behavioral and Cognitive Therapies has training videos and other wonderful resources. The National Child Traumatic Stress Network has information about numerous models that serve children who've been through trauma. The National Center for Telehealth and Technology has great apps and other resources. And then I have some recommended readings that I have found helpful to really deepen your understanding of cognitive behavioral therapy.